Welcome to Distance is No Obstacle, the medical education podcast aimed at providing bite-sized education and information for doctors working in rural and remote Australia. Today we hear from Vineet Padmanabhan, who is a consultant and child and adolescent psychiatrist. He is joined today by Dr. Olga Ward.
Vineet, thanks for joining us today.
Thank you so much for having me here.
Tell me a little bit about anxiety disorders. How do you define them?
If you look at the dictionary, the meaning of anxiety is distress or uneasiness of mind caused by fear of danger. Mm-hmm. So that is what the word anxiety means. Now, what is anxiety disorder? It's a general term for frequent bouts of nervousness, fear, apprehension, or worrying which appears without a reasonable cause. This is one of the textbook definition of anxiety.
We often see adolescents with, I've got anxiety, they'll say, or, they've clearly been diagnosed with some kind of anxiety disorder. How much overlap is there with other diagnoses? And, how do you actually kind of plonk a diagnosis of anxiety disorder onto an adolescent or a child?
Yeah, I know that, yes, in rural areas you may find it difficult to find help. And it does make one wonder when you have these 6 or 7 year olds who come to you and you give them diagnosis of generalized anxiety disorder, and it is there on the GP record or on my health record, and it's there in the system. It's quite a common condition, one literature says it's 1 in 3, and the other one says 1 in 5, and there's 1 in 8. So, but it's around, at least I would say, proper disorder is around 7 to 8%. Whereas then you have all that free-floating anxiety, where people are functioning but just managing somehow. That would be quite a significant proportion of the population as well. Yeah. So it's a very common condition, more than what we think. Vague anxiety will be something which they would come and tell you, I'm feeling anxious. But they're not telling you that it is actually impacting their functioning.
So this is just sort of some vague background thing that they feel a bit on edge the whole time?
On edge the whole time. So one of the things which you could ask them is, do they feel this way always? Or is it related to a specific thing?
When kids particularly are needing to access some kind of support service, and I'm thinking also in rural areas, sometimes they'll need a mental health plan and they actually need a diagnosis. And I'm always very reluctant to put any kind of, diagnostic box on a young person because that's on their record forever. How do you work around that?
If there is a problem and if it is impacting functioning, until you make a diagnosis, how are you going to formulate a treatment plan? Just like with any medical condition, I know that it will be on record, but if somebody has a severe anxiety disorder which requires psychology input as the first step towards treatment, I would actually put that because you need the diagnosis.
I think if they're having a really huge functional impact, you need to put a diagnosis, but those other kids that are just kind of vaguely anxious and on edge all the time, to try and access services in rural areas, sometimes you are actually needing to put a label in order to access the funding for the service.
So if they don't have that severe end of the anxiety, which you would label as an anxiety disorder, are there online, resources which you could use?
Then you can start to look at some of the other stuff rather than going through the local mental health service.
Yes.
And we're probably getting a little ahead of ourselves here,
So I think if you have somebody who's presenting with some vague anxiety, they are continuing to function, there are self-help books which you could look at. There are quite a few books for children which could be used.
Yeah.
And
such as
the one which I recommend to parents is the Whole Brain Child. which is my recommendation. But
is that for the parents to read or for the kid to read?
For parents to read, but there is literature which I can always send in terms of.
So we'll put that link up on our website if you've got a list.
Yeah.
One of the books I've always used for many of my patients has been Living with It.
Yeah.
Which is Bev Asbot's book, and I just like the patients are like, oh, a book, and you can see them kind of glaze over because they think they're going to have to read it, and I say, oh, it's just cartoons. And I think that has been a really good for most people will engage with it because it's amusing and it's cartoons.
One very important thing with any mental disorder is, especially with anxiety and depression, is that psychoeducation of what is their problem and that giving them that formulation as to why they are presenting with this presentation is very important. That on its own, I think, is a significant part of the treatment, actually, that psychoeducation, so that they know what's going on with them. And then moving on to, if you don't have access to psychology and therapeutic interventions, is going on to some self-help. Bibliotherapy is quite well recognized, self-help books. And the other thing is online. You have Mood Gym, you have eCouch, which they're like Mood Gym has 1 million plus subscribers. So it's world renowned now, which comes from Australia. Yeah. And they have a German version of it. So it's definitely working. And it's something which I would recommend for young people to access this Mood Gym.
Yeah, I think I've recommended that to quite a number of patients of all ages for various problems. Yeah. I think that they can engage okay with that.
Yeah. And there are lots of apps, but again, with apps, there is the Headspace app which young people can use, but it's still Smiling Minds. These are all early stages. Nobody has done any randomized control trials on any of these apps, and we'll have to watch the space. Yeah. And there will be in the future more technological advances made in this space.
I think the biggest problem for most patients, and particularly with mental health disorders, is the amount of work they have to do themselves to overcome it. It's so exhausting for them. And, I think they're all just often at the stage of, can't you just give me a pill to fix it?
It's part of the current society where people want quick fix, but this is a long-haul problem. Yeah. Anxiety, it's not going to go away.
No, and I think it's lifelong. So when patients have an anxiety disorder, have you found any kind of common threads, sort of life events that seem to tip people over, or things that maybe as GPs we could be aware of that we can help to support and head things off early?
If you look at most what we call anxiety disorders, it's not just one thing. It may not be just a life event. They could be having an anxious temperament or an anxious personality, and a life event would just trigger the whole episode of anxiety. They're always traveling at that anxious. They're always anxious. They're functioning, but a life event would just destabilize them. That's when they come to you.
And then mum and dad are usually quite nervy types as well, and grandma and Auntie Maud and the dog.
Yes, and anxiety is quite contagious, just like happiness is contagious. And anxiety, there's not one cause. So you would have life events, you would have genetics, you would have other environmental factors, personality, temperament, all these things play a part.
And do you tend to explore, when you're talking to the patients, any particular types of trauma, or are you looking for other concurrent diagnoses with your patients?
When they come to the mental health services or see a psychiatrist or one of the therapists, they go to a private clinical psychologist. Usually you would have 45 minutes to an hour to take a comprehensive history. So a good history with the standard history of presenting complaint, going through in a chronological order as to what came first. So you will have to take a detailed history. It's not just about pinpointing one traumatic event. You also need to try and understand what their premorbid personality is, the traumatic event could be part of the history. I think you have to take a good history and then formulate the presentation. So it's not just the traumatic event. But in PTSD, yes, you will have to focus on what the event was and what are they currently avoiding, and are they having flashbacks. But generally in anxiety, you will have to take a history, looking at predisposing, precipitating and perpetuating factors. So traumatic event could be one.
Are there any developmental conditions that that kind of predispose young people to developing anxiety disorders?
Yes, when neurodevelopmental conditions, or if people have intellectual disability, they are at risk of developing anxiety. The ADHD and autism spectrum disorder, there's a significant comorbid anxiety. So one with ADHD, it could be as part of the ADHD.
Yeah.
Or it could also be a side effect of the medications which are prescribed in ADHD. So the stimulant medications, one of the commonest side effects is anxiety. So you need to try and work out which came first. So if you have somebody coming to you with ADHD and anxiety, it's very important to find out what came first. So if it's stimulant medication induced anxiety, then it's very important they get that medication reviewed by the prescriber. So that's something which you need to work out. But there is a significant overlay of anxiety in ADHD as it is. And that's why the diagnostic assessment also has to be done very carefully, because some of the an anxious child also could present as fidgety, hyperactive, impulsive. So it's very important to do a comprehensive diagnosis.
Yeah. Do you have a magic question or a magic thing which tells you, gosh, this child is more ADHD, or more this is primarily an anxiety disorder?
Yeah, so a good ADHD assessment, you need to take good collateral history and information. So you would collect information from the school, both in a structured questionnaire format, and also you would give them other questionnaires which the teachers have to fill. So it's a comprehensive assessment. And ADHD has to be a very comprehensive assessment, where you collect information from the school, you collect information from the parents using structured and other semi-structured questionnaires, and then you observe the child in the clinic also. And you rule out for other mental disorders when you're doing the ADHD diagnosis. Otherwise, you will end up treating the wrong thing.
Yeah.
And you would have more anxiety coming up, and more fidgety and more hyperactive once you start the medications. So the assessment is very, very important. It has to be done properly.
In terms of the ADHD medications, in somebody in whom, because as GPs we will often be referring these patients for assessment, and we often have a fair bit of family information, like how do we flag that with the paediatrician that we're sending for a diagnosis?
For ADHD? Or?
For ADHD, like if they're going for an ADHD assessment and you think, gosh, I think there's a fairly significant anxiety overlay, and is there a particular ADHD medication that is less of a problem for anxious kids?
I think it's again because of the way, because of pharmacodynamics and pharmacokinetics, it's very difficult to predict.
So it's like all psychiatric drugs, it's suck it and see.
Yeah, I think psychotropic, but ADHD medications have been around for some time now, for many years, many decades in fact. So it's one of the most studied drugs. So you more or less know the side effect profile in a good proportion of the population. Whereas the other psychotropic medications, I would say, it's still early days. But it is difficult to say a particular drug will cause anxiety.
Yeah.
But if somebody is already predisposed to developing anxiety, introducing a stimulant medication, there could be a risk, a potential risk of anxiety symptoms coming out, and them presenting with anxiety.
One of the other groups of patients that we tend to see rather a lot of is young'uns on the autism spectrum. And sometimes they're quite difficult to connect with and certainly difficult to engage in some of these therapeutic things, although many of them do quite well with the online programs like Mood Gym, I think just simply because they're only interacting with the computer. Do you have any tips for assessing and helping them?
Autism spectrum disorder comes with a significant level of anxiety as part of the presentation.
Just because of the overwhelming input.
Yes, and sensory. So there are lots of contributory factors to it. Sensory could be one. And again, it's about your body's reaction to that sensory, being hypersensitive to the sensory aspects. And so the treatment side of it, you use a package of care, as you know, through NDIS. They could get a package of care which involves occupational therapy, there's sensory modulation done as part of that, then you have psychological interventions, and it depends again on some individuals benefit from other unconventional therapeutic options like equine therapy. Some people do well with physical activity. So there is actually, it doesn't say that this particular treatment is available for people with autism. It's a multiple, and we'll have to test it out as to what works for them. And it's a difficult one, and that's why the best outcomes you get when everything is under one roof. They get all the therapeutic interventions from one place where they're all talking to each other. And in the end, if that's not working, then medications, just like with any other anxiety disorder, you would have to be looking at medications.
And of course, with rural, we've got the added disadvantage that the services are sometimes a bit piecemeal and less coordinated, or you get a local team, but it's missing 3 or 4 members. So you might have in the town, a visiting occupational therapist who comes once a month, and a physio who's there intermittently, and a psychologist who's mostly there on a TV screen. It is challenging. It's complicating.
It is challenging. I don't know what is the solution. However, with the COVID-19 situation, people have benefited from video conferencing, therapy being delivered via video conferencing. I've heard of even physiotherapy being delivered via video conferencing.
Yeah,
and
it's quite difficult to prop your phone while you're trying to do the exercise.
Yes, I completely understand, and I'm seeing a lot of virtual reality things being used to deliver all these therapies. And there is not enough research done on children or young people with autism and how do they relate to the video screen, especially as part of psychological interventions. I've heard that they relate better to people through screens rather than sitting in a social setting.
In a room.
Yeah.
Whereas the rest of the anxious kids who have just got the anxiety disorders seem to benefit much better from having a soothing presence right there. Difficult. And of course what usually happens in a rural setting is that they end up back at the GP with a 15-minute time appointment slot with those kind of very short interventions, and they are often brief interventions, particularly if somebody else is making the appointment for the kid. They often don't think that, that it's going to be complex and take longer than 15 minutes, so they don't make a long appointment. What kind of brief intervention hot tips do you have for GPs?
A good assessment of a young person, I'm talking about children and adolescents presenting with mental health difficulties or emotional difficulties. I don't think it can be done in a 15-minute slot.
Not me either, but there you go.
Because you're not only assessing the child, you also need to find out what's happening in the family, what's happening at school. So it's a comprehensive assessment, includes all those things. So you're not just seeing the child in isolation either. So it's very difficult for me to say there's a brief tip, here you go, it'll solve the problems. So my suggestion would be not to be in that brief intervention space. Okay, if you want to look at brief intervention space, again, relaxation strategies. Is there anything which you can do in that space? I'm aware of GPs who are into mindfulness. Mm-hmm. Is that something which you can practice with your patients and families in that 15 minutes session? Mm-hmm. But I don't think there is any, immediate 15-minute brief intervention fix.
Block a series of appointments for those patients and let them know that this is serious and that we can do something, but we've got to do it kind of as a marathon at half an hour a week.
Yes.
Something like that.
And most of this also includes homework, which they have to take home.
Mm-hmm. What sort of things would you get, I don't know, say a 13-year-old to go home and do?
There's not much in the literature about using apps like the mindfulness apps. Mm-hmm. Some kids benefit from it. Mm-hmm. The really motivated kids use it and they benefit from it. But if you're seeing
the motivated kids who've got enough insight into what's happening to them, who can go, oh, I am getting very anxious, it must be time to switch on calm, and they go away and do it.
It takes practice, and I think it requires a lot of motivation. So that's one of the things which you can do as part of your assessment, is to assess their strengths, mm-hmm. as to how motivated they are. So
assessing a kid's strengths and not just their problems.
But that's very important in your assessment, especially with, I would say, with anybody, but with children, strengths.
How do you ask them about that?
I think you can ask them, for example, sports. Is there anything which they are, what do they do, what do they enjoy, and what are they known for, and things like that, yeah. So things which they are good at. Again, it's about how do you package the problem which they are presenting with. Yeah. I would say these are things which they can improve. Yeah. Yeah, and giving that framework on its own would have a positive impact on their thinking, to say that yes, we can move on from this, rather than it becoming a lifelong
I've got a problem.
Yeah.
And like I've got diabetes. I'm like, yeah, well, we can manage this.
Yeah, it is not I've got it is diabetes. This is my thought. This is not me. Yeah. So that is the kind of work which has to be done as part of therapy, is to disconnect their thinking from themselves.
How do you start with that?
Well, it's not going to happen in 15 minutes.
No,
It's definitely not going to happen. It's a long haul process. I would say when your mental health care plan, 10 sessions. Yeah, no, it's not enough. 10 sessions, which is spread over a year in some cases, is not just going to happen. Yeah. And it's not just children, the parents also have to be motivated. I'm talking about 12, 13-year-olds.
Yeah.
Also have to be motivated.
And if they're not, then you have to try and find or build a support network, or help the kid build a support network outside.
For a 16, 17-year-old, it may be possible, but for a 12, 13-year-old,
Little ones I sometimes find, they can talk to, their 17-year-old older brother,
that's a good
or their
point.
Sports coach, or their Auntie Maud, or their grandma.
It's a good point. I think talking to somebody who is not judgmental and is able to scaffold them or support them through this is very important. So if they are in families where there's a lot of anxiety, and they go with anxiety or go with an issue to their parents, and then the parents kind of are finding it difficult to deal with, if there is somebody else who would be able to support this child, grandparents, for example, or you could have an uncle, an auntie, or a family friend who is able to contain the situation rather than making it more contributing to the anxiety. That's where I think when schools play a part. Yep. If they have good pastoral support in schools, if they have a good school psychologist who would be able to support this child, will be quite that will help.
Yeah. Now, most of the adolescents particularly will come in with a letter, and they're asking for extra time to complete their exams or their assignments. And of course, in our day as med students, we'd have just been told to suck it up and get on with it and achieve. And clearly there is now some support available for those kids to take a bit of extra time or have a little bit of extra leeway, with the hope that they won't be needing that forever. How do you word something like that when you're trying to write a letter of support? And is it something that we can assure them that with some effort it's going to get better? Because clearly, you know, most of the kids who are doing exams and assignments are not stupid, and they're looking, going, gosh, you know, I want to get into nursing next year, was my most recent one, and I'm needing extra time for exams. What's going to happen when I'm on an emergency department shift? You know, they're already jumping ahead to, this is going to screw my whole life.
Good, and it's a good point. I must say that, you know, you're thinking around, okay, you know, in your days or in my days, we had to just suck it up to the exams, you know, anxiety doesn't matter, you go do it. However, I think when during our times we didn't have this level of pressure with other things. So there is social media, there are lots of other things which young people have to keep up with. So it's not just about exams or sports. There are lots of other things which people have to keep up with. They're judged on. So there's a lot of anxiety which is kind of being generated with all the other activities which young people get involved in. And when you have somebody with an anxious temperament, it'll be too much for them to cope. So you have some kids who would come to you who are finding it difficult with the exam situation. For example, there's so much of anxiety, they're well prepared for the exam, but when it goes to when the exam happens, they go blank. They get anxious. And it takes, and most of them actually with giving them some time, they will settle down and then they will be able to give the exam. And that's where I think they're coming to you to say, I need extra time.
Yep.
And so they have a genuine problem there.
Yeah.
It's not a child who is able to do the exam. They're not just coming to you for, I need more exams because I'll be able to write that additional 2 questions. I could be able to answer them. It's not about that. They're genuinely anxious. And you're saying that they're genuinely anxious. So your question is whether if they are not able to do this, how will they end up doing nursing and becoming, you know, working in an emergency department? But if you look at...
It's usually their question, but
Yeah, but majority of these kids, they have only a specific anxiety, which is a kind of performance anxiety, which is in this situation related to exams, which you want to give it a label, you could call it as test anxiety. But you don't see this level of anxiety with other things. So if they end up being a nurse in an emergency department or a doctor, you wouldn't be seeing them in that anxious state later on in that particular field. Whereas if they have to take an exam, they may again come up with the same level of test anxiety, but it's not something which you would see in a generalized way.
Apart from kind of asking for the extra time, do you then kind of go through, or get the psychologist to go through some relaxation strategies so that when they do get to the exam and look at the paper and their mind goes blank, they can just go and kind of drop it off and then get going?
You could have the world's best psychologist teach somebody relaxation strategy. It's not going to happen overnight. Relaxation comes with practice.
Yep.
At least, I would say 6 months practice. This is what I think. It's not going to come overnight. So it's something which you can use to switch off. Yeah. When you are put in a state where there is anxiety-provoking situation. But it takes time. So it's not going to happen overnight. It comes with practice. So you could give them a letter to say that they need some support and help. Once they are out of that exam situation, it may be about bringing them back and having that discussion on how do you want to address this. Because this will be an ongoing issue. You will have many more tests to take in the future. So how do you want to address this? Only if they want to address this, then you can put in some things in place. So it will be about drawing out a plan. I know that you don't want to give labels, But this is a classic case of performance anxiety. So you can put it under the anxiety disorder label and get a good psychologist to work with these kids to come up with using a CBT approach to come up with some relaxation strategies as part of that. Because this will be a lifelong thing as long as they've been taking tests.
And do you use any medication with kids in these kinds of situations?
With test?
Well, sometimes it's the kids with performance anxiety, and sometimes it's the kids who just have an anxiety disorder who don't have anything else attached to it, like they're not autistic or ADHD. Is there anything that you found really, really helpful?
It depends on the situation. So if it's a test situation, if there's a very important test which they definitely have to take it, means the problem with most of the benzodiazepines is it can impact your memory. So you take it in the night and then it may have an impact on how you perform the next day, and it could be counterproductive. So generally, benzodiazepines are not advised. With this, the only solution is to calm. Generally, adult psychiatrists may prescribe medications, short-acting benzos, but I'm not aware of many child and adolescent psychiatrists prescribing benzos. So from a medication point of view, there's not much
that you can use in an acute
for
situation.
a kind of test anxiety.
What about the chronic, the ones who are kind of generally nervy all the time? Any of the antidepressant type things worthwhile in those kids?
So if you have generalized anxiety disorder or any of the other anxiety disorders which you have thoroughly assessed, you have realized that you have come up with a formulation of anxiety disorder impacting functioning, and you have tried psychology, it's not working, the second line will be medication. And the medication should be part of a comprehensive treatment plan, which should include psychological interventions. So from a medication point of view, we would be looking at the SSRIs. And there is no specific one which you should use. You could use fluoxetine, you could use sertraline, you could use escitalopram, citalopram. I wouldn't be prescribing any of the other kind of antidepressants. These are the four usual ones which you would be looking at.
They're the ones with most of your anxiolytic effect,
Anxiolytic effect. Generally, antidepressant medications have good anxiolytic effect in children. So when I say good anxiolytic effect, actually the anxiolytic property of antidepressants in children is better than its kind of antidepressant thing. So the anxiolytic effect is pretty good. When I say pretty good, it again say not in all children, but in majority of children. So it does help when everything else doesn't work.
And do you just prescribe on a milligrams per kilo basis?
Not in a milligram per kilo basis. So what you would look at it is, my general advice would be to start low, go slow. So let's say fluoxetine, I would actually start kids on 5 milligram and then give them a call to see how they are doing. There are no side effects, especially with increase in suicidality and self-harm. You need to monitor that for the first few weeks after you start any antidepressant medication. So after a week, I would actually, if they're doing well, no side effects, there's improvement in symptoms, then we can go up to 10 milligram. The maximum I would suggest you go up to is around 30. And in fluoxetine. After that, I'm not very sure if it will really work. So SSRIs would be first line of medications.
Now, I noticed that you mentioned self-harm, and that also seems to be something that we see quite a lot of in adolescents. Doesn't seem necessarily to be linked that much to anxiety. Can you tell me just a little bit about self-harming kids or self-harming adolescents and what we need to look out for, and if there's any kind of hook where we can kind of connect with them to help.
But I think self-harm is an important thing to keep in mind when you're seeing children with anxiety or children presenting with depressed mood. Because one of the other things which we didn't touch upon as part of the anxiety is the most common comorbid condition is depression.
All right, so we'll watch this space and see whether in 50 years we've had a change in funding. Do you have any final take-home messages?
I think the final take-home message for GPs would be about if you are prescribing medications, it is about starting low and going slow. Start them at the lowest possible dose. You can, if it's fluoxetine, go up to 5 milligram, half a tablet of 10 milligram, and you would see that on its own would make some difference. Or if you're going for go to the lowest possible dose. That would be my advice, and don't start and then change it immediately. Wait for the treatment response. Wait for 7 days, 14 days, 1 to 2 weeks that is, and then slowly increase it.
Yeah.
There's no immediate fix. These medications, even the medications will take some time. And if you are feeling stuck, my general advice to the rural GPs would be to speak to the psychiatrist in your local mental health service to see if and they would be. I'm sure most of my colleagues would be able to give you that advice if requested.
Thank you so much for joining us. I feel like I've learned a bit and discovered that the problems are both widespread and not immediately soluble, but definitely able to be tackled.
Thank you.